Welcome to Voices of Esalen. I'm Sam Stern. Today, I'm proud to present a talk from our famed Esalen archives, Stanislav Grof discussing LSD psychotherapy in 1969. Grof, born in Prague in 1931, was among the most influential figures in the early clinical use of LSD. Sometimes referred to as the Godfather of psychedelic psychotherapy, Grof was trained as a Freudian psychoanalyst in Prague and was on track to follow in Freud's footsteps when that path was derailed by a powerful LSD session, and it sort of changed Grof's life path. He became one of the principal investigators of early psychedelic research behind the Iron Curtain, conducting systematic LSD psychotherapy at the Psychiatric Research Institute in Prague. Grof's approach was largely psycholytic, meaning that in contrast to the single high-dose mystical model, he favored smaller doses that could be given consistently over the course of multiple sessions, thus emphasizing the gradual revealing of the layered strata of the human unconscious. In this talk, Grof describes how the same substance can evoke vastly different experiences in different individuals, from childhood regression to episodes resembling psychosis to genuine mystical revelation. He offers accounts of patients reliving early developmental trauma and what appeared to be birth agony, followed by experiences of renewal or rebirth. He also touches upon the emergence of archetypal and transpersonal imagery in advanced stages of therapy, giving insight into the collective and cosmic dimensions of mind. Here's the brilliant Stan Grof in 1969 at Esalen Institute.
My approach has been that of an experimental and clinical psychiatrist. I have been working in the Psychiatric Research Institute in Prague, and I had a training in psychoanalysis and psychoanalytically oriented psychotherapy, and I was specializing in psychotherapy of schizophrenics, which was using psychoanalytic principles, but what was more similar to the approach of the school of Chestnut Lodge, Frida from Reichmann and so on. And during the last 13 years, I have been interested in psychedelic drugs, especially how they can be used for psychotherapy, for intensifying and accelerating the psychotherapeutic procedure. Our institute was one of the places in Europe which developed so-called psycholytic approach to LSD psychotherapy, which is different from the psychedelic. The psychedelic, as you know, uses large doses, usually only one exposure or two exposures in a special set and setting with a great religious mystical emphasis, the use of music and so on. Whereas our approach has been a repeated administration of LSD or psilocybin or other drugs within a psychotherapeutic framework, using the techniques which are used in different schools of psychotherapy. When I started with LSD about 13 years ago, we are very much impressed by the fact that the same drug, in the same dosage, used in different persons, can produce an extremely wide range of experiences. We saw people who, for example, on a high dose of LSD, didn't experience any perceptual phenomena, but the whole LSD session was experienced like a physical illness. They were somatizing all the time. We saw other people who experienced the whole LSD session as a sequence of sexual orgasms or sexual tension without having any other phenomenon. Some of the subjects regressed into childhood and reported complex reliving of traumatic childhood experiences. We had some of the subjects who experienced a real schizophreniform episode. And then we had a few subjects who experienced what seemed to be a genuine mystical religious experience. So we were impressed by this fantastic range, clinical pictures which a single dose, a single drug can produce in different people. And we oriented our research toward explanation of these phenomena. So we worked at the beginning with patients whom we knew in great detail, with whom we spent many hundreds of hours in psychotherapy, individual group psychotherapy, where we knew the life situation and so on. And then we gave them LSD, and we wanted to find out whether we can understand something about their reaction to LSD using all this information about their background. And finally, during this kind of work, we developed what we call the psycholytic approach, because we felt that this can be used not only for diagnostic purposes, but also as a very effective therapeutic technique. So our last experience has been based on more than 50 cases of different clinical categories. We wanted to have a wide range of clinical diagnosis, patients with different diagnostic categories, and we treated them with the psycholytic approach. In other words, we established the psychotherapeutic contact with them. Then we went on with repeated LSD sessions, where the number ranged anything between 15 and 90 or 100 sessions for each individual patient. We made very detailed protocols of the sessions and also of what was going on between the sessions, and we wanted to find out whether we can understand something about the underlying dynamics of the exposure to LSD. And as you know, after some sessions, people can feel wonderful, can feel purged, reborn. After some sessions, they can have an experience of hangover, and after some sessions, you can get something like a psychotic decompensation or a freak out. So we were very much interested whether we can understand something more about in what kind of persons this happens, under what circumstances, or if it's related to some specific material from the LSD sessions. Now, our present understanding of LSD is that it's more or less an unspecific catalyzer, which just brings up whatever is in the personality, and that this procedure of repeated LSD sessions actually is sort of subsequent revealing and integration of deeper and deeper layers of personality. We saw our patients going through what seemed to be typical Freudian material, reliving of childhood experiences, working through all kinds of hang-ups and so on, and going through the agony of birth, going back even to intrauterine experiences, and in the advanced stages of the LSD treatment, having what they described as karmic experiences, going into past life, having mystical religious experiences, archetypal experiences which seemed like those of a collective or racial unconscious and so on, going back to different cultures, Egypt, India, and so on. Now, what can this kind of experience with repeated administrations of LSD contribute to the problem we would like to discuss in this meeting? I think first of all, we saw that in some sessions, some subjects in some sessions, or between some sessions, experienced phenomena which were very, very similar to those of endogenous psychosis, whereas other sessions were completely different. And I think we got some kind of insight which the sources of these sort of psychotic freakouts in the LSD sessions are, or in between the sessions are, which seems to throw some light on the understanding of endogenous psychosis. The second interesting aspect is that in this wide range of patients, we had also several borderline psychotic patients and several of them who were clear-cut psychotics, who were schizophrenics, and who went through this procedure of repeated LSD sessions. You might be interested in what happens to schizophrenics if they are exposed, let's say, to 80 or 90 LSD sessions within a therapeutic framework, and what the therapeutic results are. And the third aspect of the work with psychedelics to this particular topic is the problem of what was labeled here positive disintegration, because we saw very dramatic therapeutic changes in the patients after certain characteristic experiences of disintegration, which we might discuss in greater detail. There were 3 of us, and we had more than 50 patients. The number of the sessions is more than 2,500 sessions. And we made detailed protocols of the sessions and of the free intervals, and we wanted to find out some regularities or some general laws. Then after I analyzed these protocols, I was trying to make some kind of general scheme which would help us to conceptualize what was going on in the sessions, whether there is some kind of general way how to understand the whole procedure of repeated LSD sessions, and what it means, for the understanding of the personality structure and personality functioning. The scheme is extremely oversimplified, so I'm apologizing for it, but I didn't find a better way how to put it. Just to give you a general idea what was going on in the patient during the LSD sessions, we could roughly divide the persons into three categories. One of them who were sort of average adjusted persons to start with. Another group which were neurotic patients, fixated neurosis, psychosomatic cases, borderline psychotics. And then we had a small group of patients who started as clear-cut psychotics. Now I would like to tell you what we saw in the repeated administrations in these groups of patients. Now I will start with the middle group because it seems to be most illustrative. Now if this is something like average adjustment, and this is the area of neurotic symptoms, and this is the area of psychotic symptoms, we have to accept that this is continuity. Not all people would agree with it. Some people feel that qualitative gap between neurosis and psychosis. My feeling was that, we can demonstrate quite smooth transitions between neurosis and psychosis. So this would be the range of neurotic decompensation. This would be the range of psychotic decompensations. Now, when we started with our neurotic patients, with the middle group, you see, they were very severely disturbed. They were very low or high on the, on the neuroticism scale. Now, what I described that what we wanted to do was to establish a good therapeutic contact, to go through the whole life story with the patient, to help him to conceptualize his symptoms, his life problems, the relation of the symptoms to their life situation in the almost usual way. In the later stages, we like to make a detour from the conventional sort of psychoanalytic type of procedure by being more direct and by focusing more on the positive potential in the personality than on analyzing, detailed analysis of the psychopathology. In other words, during our work, this was not at the beginning, but during the work, we tended to focus more on whatever is left from the positive potentials, than to having this morbid interest in whatever was psychopathological and trying to understand the whole mosaic of the pathological structure. So there was a greater emphasis on the positive potential, but in general, we went through the whole history of the patient in the more or less conventional way. Then we started the LSD sessions. Now, if this is the first session in the neurotic patient, and these are the subsequent sessions, in other words, the whole order of the sessions, what we saw was that after some sessions we got a major improvement. Again, we could speak more about this. It seemed to be related to certain specific constellations of traumatic memories, which formed clusters within the personality. And when the patient in a particular session was able to make a sort of a partial integration and had a good re-entry from the session, we saw sometimes a very dramatic improvement from clinical point of view, from point of view of life attitudes, hierarchy of values, and so on. But if we went on, it could happen that the next session ended in a bad point, when the patient just about sort of stirred up something or triggered, something was triggered but was not solved in that particular session. We could get, for example, intensification or even a prolonged reaction. The patient or was under the influence of the unconscious material which was activated in the last session. So he could sort of drop back, and this is how it went. There was a general trend toward improvement, but there were ups and downs in relation to the separate sessions. Now then the patients, I should say that this was done retrospectively, this kind of thing, when you are in it, when you are trying to explore it, there are just separate phenomena which you cannot make. But when you have the protocols of a great number of patients, you can read them in a very quick sequence. For example, in one afternoon, you can go through the protocols of a whole series of sessions, and then you can integrate the material. You can get some idea what was going on. So when I analyzed the protocols retrospectively, I could see that the patients reach a point of a very good integration, of a very good clinical improvement at a certain point after going through all this. Now, we proceeded with the LSD sessions, not because we were not satisfied with the outcome, but because in the LSD session there still were problems. There was aggression, anxiety, there were all kinds of somatic symptoms. And because I had the psychoanalytic training, I felt that what we have achieved was just a symptomatic improvement. And in order to prevent relapses, that you have to go on and resolve what I felt, could be the rest of the problems on the contrary. But this was a great surprise, because what we saw was a sudden deterioration of the patient. Now, at the same time, if you analyze these sessions, you'll get a lot of Freudian material. They will be regressing to childhood, going through traumatic experiences of childhood, solving the Oedipus situation, the problems of the different, seems to be almost a proof for the Freudian theory. So many of the phenomena which we saw here could be understood in Freudian terms. Now, after they reached this point, the sessions became more and more transpersonal. There was very little of the childhood material. If anything, we saw reliving of operations, of situations endangering survival or body integrity, but not the kind of, more subtle psychological, conflict with the father, mother, sibling rivalry, things like this. But these were vital things. People went through injuries, through operations, through dangerous diseases, especially those which were somehow related to breathing, like pneumonia, drowning, smothering, things like this. Now, the sessions became very, very transpersonal and very specific. And an interesting phenomenon happened. The patients belonged to different categories to start with, because we wanted to cover a very wide range of clinical diagnosis. And their LSD sessions were completely different. Whereas here, it suddenly converged. It tended toward the uniform symptomatology. In other words, patients who started with different problems suddenly had the same problems to face in the sessions. And the prevailing topics were suffering, death, agony, apocalyptic aspects of the world. The world seemed to be full of aggression, pain, suffering, kind of thing Buddha speaks about, the noble truths concerning suffering. Or sometimes some patients had visions which were resembling the, visions of Christ in the Garden of Gethsemane. All the evil of the world was sort of coming to them, flooding them and so on. There were typical somatic symptoms, which was always a tremendous pressure on the head, on the body, pressure of the chest, suffocation, tremendous tension, muscular tension, which was discharged in all kinds of twitches, jerks, twisting movements. There was profuse sweating, which was part of this syndrome. Always cardio symptoms, tachycardia, palpitations, feeling that there will be a cessation of the pulse. Heart rate, the start is going to stop. The heart is going to stop. So, and there was nausea. It was one of the somatic symptoms which came to the foreground in these sessions. Of course, it is sympathetic as well as parasympathetic. It's not only the sympathetic arousal, because nausea, is the vagus reaction. Also, in the free intervals, as you see, this was a great clinical worsening of the clinical condition. And also in the free intervals, the symptomatology was very uniform. It was almost the picture of endogenous depression. They felt cornered or trapped, feeling that they are in a situation of no exit. Some of them had the feeling they understood Sartre, no exit, on a more subtle interpersonal situation. Hell as understood as sort of insoluble, unbearable interpersonal situations. The work looked different. It was dark. It was the way the melancholic patient described it. They had the feeling they don't have immediate contact with the world. Something what separated them, some kind of film, dark film. Also, these sessions are in dark colors. I don't think I mentioned it. Whereas, here you get very frequently brilliant colors, the fireworks, explosions, and so on. Whereas these are sessions which are very dark, ominous, usually given in gray-colored, ominous violet or poisonous green, dark green, things like this. They were facing immediately the problem of death, the fact that we are mortal. Some of them in the sessions experience worse agony, going or identify the agony as being derived from the hours of agony which we actually went through. At the same time, they experienced, because you can experience on many levels, as you know, many things can be going on simultaneously. So one level of it was as a very general thing, suffering mankind, thousands of soldiers dying in the battlefields, terminal patients, dying in pain, agony, mothers dying during delivery, things like this. On another level, it was the birth agony, at least in some patients. On higher levels, there could have been a mixture of some kind of pains related to operations. Like there was the general agony of birth, but at the same time there was a localized pain, which was identified as, for example, tonsillectomy, and some other disease could be related to another painful experience from lying. So it formed kind of clusters. What was in common was that these were experiences of vital emergency or, endangering of body integrity, survival problems, and so on. Then there was a projection of this agony to the end of the life. They very frequently anticipated and saw themselves dying in the future when their life terminates. And now, of course, this was closely related to the problem of meaning of life. Because if we are mortal, if we come to this world without having the choice as to when, where, and to whom we'll be born, just to go through all kinds of, unpleasant things, suffering, with the only certainty that we'll end in agony. Now, this, of course, has to activate the problem. What is it all about? What's the meaning of it? And it was extremely, extremely painful. This kind of existentialist, very, very burning problems. And of course, there were always here the experiences of anxiety to or fear that they are going crazy. It was so overwhelming. There was such a flood of things which couldn't be integrated. It led to disorganization and feeling, my God, I'm going out of my mind. You see, my present feeling now is that this, on some level, is related to the birth trauma, because you had to go through the life history, and these things happened after the very early oral experiences and so on, when this area opened up. So I believe that this was the moment when they got into contact with the imprints of actual agony of birth. So all the things of being trapped, being, imposed upon by an overwhelming external force makes sense if you accept the fact that this is related to the birth. Also the fact that this is a situation of complete isolation, which is the situation during birth, and situations of vital emergency, everything is alone, because you are not able to maintain any contact because you are worried about whether you get the next breath or not. And of course, what was one of the proofs for me was the specific cluster of somatic symptoms. When I saw this for the first time in the LSD session, I was frightening myself because, we didn't exactly know what we were doing. It was a completely new thing. Suddenly I saw the patient, who was turning blue and red, had all these muscular twitches, cramps. His pulse was hardly palpable, it went up to about 170, 180. Of course, I have the medical background, so for me, this was associated, to some real shock situation. So my first idea when I saw it was, my God, I have, caused a kind of central dysregulation, and this is going to be a real, physical shock. But later when I saw it again and again, I got used to it. And
This was after how many sessions?
This is a good point. For reasons which I don't know. You see, in some patients this could happen after 12 or 15 sessions. But in some patients you have to go up to 60 sessions before you get this. You can get elements of this kind, but on a more superficial level in the first sessions. Many people can have the feeling they were boring, but it can have a very mitigated form of getting out of an eggshell or, being purged, or sometimes they can have the experience which they relate to reliving of a traumatic aspect of their past, like being in some of the past traumatic situations, feeling trapped in it, oppressed by it, and then suddenly resolving it. And it feels like being reborn. But it seems to be different from this, because then you get it in the, in a concentrated form. So they sometimes told me, when they went through this, they said, how could we take these rebirths seriously? Because this was like dying, these were hours of actual dying, last things in the human life. You see, everybody probably feels, at least from the patient category, felt that it's time to stop here. You shouldn't play a fool around with things like this. So it very frequently took a lot of work, we had to pursue it and to go on. It was an extrapolation of some of the things which we saw here, because we knew that when we get turbulence in the patients after an LSD session, it means that something was stirred up but unresolved. This is where I got the personal believed that the time when you can stop LSD treatment is after a good session. But if you have a bad one, you have to go on and work through whatever is the underlying problem. Because otherwise it can take a long time before you cover it up, if you should have stirred up the deep layers. So here it was, of course, much more difficult to make the decision that you go on, because you were already, playing with psychotic phenomena. Here it was much, much easier. Now, I mentioned that there was a specific syndrome between the sessions in this category of patients, which was the picture of the endogenous depression, the questioning of the values of life. There was always overwhelming anxiety, which had the character of kind of free-floating anxiety, which could be attached to all kinds of situations in life. It could be experienced as a street phobia, it could be experienced as fear of the boss. Whatever aspect of life could become as it the source of this anxiety. But of course the anxiety was coming from inside and was just sort of rudely attached to these things. There was always this existentialist problem. Why are we here in this world? What is it all about? Meaninglessness of this existence and so on. And there was this typical cluster of somatic symptoms which also persevered from the sessions into the free intervals, like the headaches, especially with the belt headaches, which we very frequently see in neurotic patients, the feeling that almost a belt is being tightened around the front. Then these cardiac problems, palpitation, lack of oxygen, feeling that they have to breathe deeply to get enough oxidation. And nausea seems to be a very, very typical symptom for this period. Now, this can go on for several sessions, usually for 5 or 6 sessions. So there, as you can imagine, there are hours of agony and extremely painful periods before this is worked through. And there can be several rebirths, can be the feeling that this was resolved, but in the next session, the patient has to go back. But in general, the unpleasant experiences seem to recede, and the positive side seems to take over. But there is a moment, the experience of complete annihilation, disintegration, ego, loss of identity, and then it explodes into the reverse experience, which is the opposite. The mind was full of suffering. There was almost nothing than negative things. Whereas here, when they get into this kind of experience, they can hardly see anything negative in the world. If there is aggression, it's sort of ephemeral, or it's just as a play, or it's not important. But the divine, the radiant aspect of the world seems to be prevailing. Natural beauty, enjoyment of one's own existence, human relationships, things like this. If you sort of analyze the phenomena which you see here in the sessions and before the session, they do not fit into the Freudian framework. And because the patient spoke repeatedly about going through the verse, I went back to the original paper on verse trauma by and I was extremely surprised, how many of these phenomena could be understood in Rankian terms. Now, if you get beyond the point of ego death, you'll get in this category of patients, you'll get, improvement. There will be a dramatic improvement, whereas some of the very severely disturbed patients become even psychotic, they can transcend this line. They can become psychotic in the meantime between the sessions. But here they are returning very quickly to the normal, and they reach a real point of integration with the specific change which I described yesterday, as far as the attitude to the world in general is concerned, to art, to appreciating human emotions, human relations, and things like that. More orientation towards spiritual things, religion, and so on. Now, if you take the other category, which is the normal, average adjusted person, they start somewhere here. You see, they don't have past history, traumatic history, which they have to go on. And if you use a sufficiently high dose, like 200, 300 micrograms, they very frequently enter these realms, dealing with meaning of life, going into agony, hell, dying, problems of the meaning of human existence, and so on. But there is a great difference if you compare these two groups, because they will have this kind of experiences in the first hours of the session. Like first 3 or 4 hours can be of this kind of experiences, but then there is the shift to the positive, and you will get a very good re-entry. And the next time, if it was, bad outcome, they will have something like a hangover. But if it was a good outcome, they will have an afterglow and a positive effect from the session. In other words, they won't be disturbed in the free intervals between the sessions. So this is the basic difference as I see it. They much earlier enter these realms of transpersonal experiences, and they don't have the turbulence, in the re-entries and in the intervals between the sessions. If you go on, be it in patients or be it in this category of average adjusted people, you get more and more material which isn't understandable neither in Freudian terms nor in Reichian terms, but many of the things are understandable in Jungian terms. Patients who never anything from Jung or heard about Jung will discover the archetypes of, Great Mother and many of the other archetypal structures. Besides, they will be having ontogenetic experiences, experiencing themselves as fetus, formation of the body. Sometimes they can descend even to the cellular tissue level of consciousness, developing tissues, but there's still the consciousness present on this level. And there will be always religious mystical elements. You'll still see negative or bad trips, but they will have a completely different quality. There won't be this experience of suffering, agony, but the negative things will be experiencing as coming from metaphysical forces, demonic forces, fights with demons, evil spirits, astral forces, and this will alternate with deep mystical religious experiences, either experienced in an abstract form, or they will be going back to some of the ancient cultures and experiencing these things within ancient Egypt, within ancient Greece or India, Middle America, things like this. So again, one unexplained thing is that each person tends to, in these advanced sessions, to go into a specific ancient culture. Some people will repeatedly go to Egypt and see how pyramids are being built and understand why the pharaohs had to be mummified, and understand all the aspects of the animal deities and so on. Other people will go into the Hindu pantheon, experience Atma, Brahma, relationships and things like this. They also could have been in Egypt or India or, in the atmosphere of 1001 Night here, but they can differentiate it. It has a different experiential quality. Here they will be willing, or they will be either offering themselves the symbolic interpretation in Freudian terms or some other terms. What it means, symbolically, that they experience themselves as Indians or that they were in India. And you can find sort of plausible explanation from their life history. Whereas here, the cultural experiences have what I would call the past-like experiential quality. It's the feeling I have been there. It's repetition of something what already happened. So it's comparable to what I mentioned to the animals. Some of the animal experiences can be symbolic, fantastic representation of inner instinctual tendencies, and the patient will be able to accept this and he will talk about it and analyze it. Whereas if he will, experience you being a turtle or a snake, he just will not admit, will not accept this kind of discussion. He will say, well, this is part of my individual history. This is the difference. Now, completed for the psychotic group, which we are, most interested in, these patients started somewhere here, and you could see the same thing, ups and downs, but the general improvement until they reached the point where they could have a critical insight. They were detached from the previous psychotic symptomatology, and the course from here was not different from that of neurotic patients. Who had to go on through all the traumatic aspects of childhood, all kinds of childhood experiences and so on. And even this was exactly the same. They started deteriorating. But a very crucial difference seemed to occur at the moment where they experienced the ego death, because this was where I expected a dramatic improvement, which I was used to see. But again, to my surprise, I got the elements of the original psychosis. In other words, we were back where we started, with the exception that this time it was a transferent psychosis. The whole psychosis was reorganized and focused upon me. And you had to go on and work under the circumstances of a transferent psychosis. And it can take, certain number of additional sessions before you reach the point of a psychedelic experience, the all is one, melted type of ecstasy. When you are able to reach this, you can see a complete restructuring of the psychotic personality, and within the course of one session, the psychotic symptomatology can just sort of disappear. About the case history, which was the most interesting patients and one of the bad therapeutic results we had. So she was a psychologist. She came into treatment after 4 months of psychoanalysis, during which she decompensated into psychotic symptomatology. There was a long history of neurotic symptoms. It was almost like a handbook of pathology. I mean, whatever is described in psychopathology you could find. There were severe depressions of an endogenous type with the morning peaks, where she had troubles to dress herself, to get up. It took her sometimes a couple of hours to wash, dress up, and so on. There were bouts of anxiety. There were minor obsessive-compulsive symptoms. There were hysterical symptoms. When she was excited, she vomited, for example, had all kinds of physical problems. So there was a very long history. The whole personality was, this character neurosis, clinical neurosis to start with. Then she, after unsuccessful treatment, she went into conventional treatment. She went into psychoanalysis, and then after 4 months, she started decompensating into psychosis. The major symptomatology was that she had a very schizophrenic family there. The erotomanic type of emotional fixation on a person. She had an emotional fixation on the boss. She felt deeply in love with him. But not only that, she felt that he was in love with her, although she didn't have any external cues. They never discussed it. He was a very detached person. But she felt that although this was not expressed openly, that it was there. He was equally emotionally in love as she were. After a while, she started hallucinating his voice. He was speaking about being in love with her. And she was in a very unhappy marriage with 2 children. Now this boss was promising her that he will arrange the divorce and he will take her to his house with the children. They will have this wonderful life, describing the future and so on. And besides, in the evenings, she had hours of orgasmic sexual experiences, which was like a distance intercourse with his boss. She has been frigid always in her life. Actually, she was vomiting whenever the husband was trying to approach her sexually. But in the psychotic experiences, she was getting sexual orgasms as if coming from this boss. Then after some time, this lasted several months, then she visited an institute and met another doctor. And the whole system was shifted to this other person. And she started really molesting him first. She wrote him letters, and then, she came into his office and started embracing him and wanted him to do what he promised in the hallucination. Now she was treated with epileptic drugs. She was treated with individual group psychotherapy, but there was no success. She did anything. She was externally calmed down, but the whole system was flourishing, was just going on. And it was this point where we started the LSD treatment. Now, here she was going through all kinds of the aspects of her past, which was terrible. She was born out of twins. The mother was severely somatically ill. She was brought up by an aunt, who was about 65 years old, spinster, very bitter, hospital. So there was a lot of rejection, even physical torture and eating insiders. She herself described the childhood as that in the Cinderella. There was a favorite brother, and there was a very outspoken sibling rivalry. I don't want to go into details. It was just one of the stories which you see in psychotic patients. From the early childhood, there was a whole seepage of traumatic experiences. Now here she went through the typical death, meaninglessness of the life kind of business, which are overwhelming, fantastic sessions, which she herself called this was a Hiroshi wrote distraction type of thing. Now for this whole period, she was able to have a very deep insight into the previous psychotic symptomatology. She could understand it in dynamic terms as we were working on it together. And my feeling during the therapy was that this was something what we left far behind, and that we were just working on the residual neurotic symptoms. And the fact that this area opened up again, after such a long time, was a real surprise to me. Now, what I saw here were all the elements of the original psychosis, but instead of the person being the boss or being the other doctor, it was me. And when she had a session where she experienced the ego loss, she suddenly started looking at me in a very sort of loving way. She was radiating these emotions. She was trying to get physical contact. She started hallucinating my voice. I was telling her the same things as the boss used to say. And what was most surprising to me, I think this hasn't been probably described anywhere, when she was psychotic, in the pre-intervals between the sessions, the psychotherapeutic interview went on in hallucination. In other words, she was bringing up questions, I was giving interpretations, so that in the extreme situation, I was in Amsterdam for the LSD conference, she was in Prague, but, therapy was going on about 18 or 20 hours a day because she was also sleepless.
Was it a repeat of the earlier sessions in which you worked with her? And were there anything from the past, or was it?
No, this was you. Well, many of the things were of the kind which I could have easily said. It was generally in my directions, but it was a discussion about new material, new aspect. It was an extension of my personality. But it wasn't a repetition, it was a creative sort of extrapolation. But I didn't disagree with most of the interpretation. It almost seemed that she has sort of, synthesized the rest of my personality, which she couldn't get access to in the previous session, that she somehow completed, my image in her mind, and this was going on in the psychosis. Now, besides this, we got catatonic phenomena. This relates to what you mentioned yesterday. For example, she stood for hours in this kind of position, in the war. Now the nurses came and, wanted her to go to bed and said, "What are you doing?" And she said, "Well, leave me alone, I am embracing you." There was a lot of joking about it because they said that she exactly picked up my thighs. Then she had all kinds of other catatonic postures, which, from the phenomenological point of view, looked exactly like catatonic features. But the difference was that when I came to her and addressed her, she could change the position and we could talk about it. And what she told me actually was that there was always one position where she could get a good ecstatic experience. But when she changed this position, she was nauseated or depressed or was getting all kinds of unpleasant phenomena. So it was kind of voluntary act. I don't know if the same thing is going on in the mind of a catatonic, but he is not able to communicate. But there was a long history of, therapeutic relationships so that we could communicate at any particular phase of this. And she could communicate with, not only with me, but with all the others. The nurses could ask her, talk with her. Just gave it up, It was a little less pleasant than the other positions, but she could acquire any position, talk, discuss it, and so on. In the sessions, there was the typical material, their phylogenetic things. She was exploring the biological pedigree, going on to the family of the father, mother, getting the atmosphere of the clans, how they didn't fit together, where the friction points were, and so all kinds of things like this. The typical material which I saw in other patients in this particular phase. There was one specific, she was able to identify some of the experiences as intrauterine experiences. And it was like space competition with the twin brother. So that she sometimes had the feeling that she had to find a position where she didn't compete with the twin brother in the womb. And then she got the blissful experience. When she moved out from this, she was getting physical discomfort of all kinds. Now, when I gave her LSD, after this period of about 6 months, she suddenly became normal in the LSD session, whereas she was psychotic in the free interval. She started addressing me, in a more appropriate way. She had a critical insight into all these things we could discuss it. When the effect of LSD was wearing off, she was becoming psychotic again. And then 2 sessions later, there was suddenly a session where there was nothing but, positive ecstatic experiences. It was the feeling of identification with nature, with other people, was good. Kind of all is one experience, well-rounded, very positive, joyful, ecstatic type of experience. And from this session, she appeared completely without symptoms. And as far as I know, from feedback, this has been maintained for 1.5 years, which is kind of improvement which I have never seen in a psychotic patient. So this is what made me feeling that the sources of schizophrenic symptomatology, besides the early childhood, as it is usually put in the psychoanalytic literature, are especially these experiences of world destruction, agony, suffering for some of the negative experiences, or especially the disturbances of intrauterine life, where there is a symbiotic unity with mother. The mother in maternal body is the whole world, and now all kinds of noxious stimuli, be it emotional distress of the mother, be it disease, be it toxic influences, really create these fundamental general distortions of the world which we see in schizophrenic patients, and that these experiences leave imprints which can be activated in later life, either by life circumstances and collapsing of interpersonal relations, which make the patient regress to these experiences, or maybe even through some, metabolic, hormonal, toxic things which act in a similar way as LSD. So if I would think about toxic factors in schizophrenia, I wouldn't think about these substances as producing the schizophrenic symptomatology, but as sort of bringing up these, sort of universal or general aspects of the psyche.
Thank you for listening to Voices of Esalen. This episode was produced in conjunction with Shira Levine. Our theme song is by Nico Holloman. Until next time, be well.